Welcome. My name is Jeff Malmgren. I do work supporting the primary care networks and their working groups and interface with community. The session we're doing today is a doc talk, how to support aging adults with disabilities and when. Just for your information, this is being recorded and in fact will be available after the session and on an ongoing basis on the burnabypcn.ca website. So if you want to share it with your friends, if you want to see it again, it will be there, as are a number of other Doc Talk and recordings that you may find of interest. This is a webinar format. We'll have a number of presentations. We've got some great presenters for you today. But you do have the opportunity to ask questions. We won't take questions after each presenter. We'll do a bit of a panel at the end, and we'll have a group of questions. But please feel free to put your questions in the chat or in the Q&A. Perhaps actually the Q&A is the best place. If you put your questions in the Q&A, and you can put them in anytime you like, and we'll do our very best to answer all of those questions. If we don't happen to get to some of them, then we will make sure that we get to them when we post it on the website and try to put some answers to some of those questions up there. So I do want to just mention quickly our panelists. I'll introduce them more fully each one as we kind of go through. We have Heather Johnson from Bachi and Pam Balag from Possibilities, and Rod McDonald from Fraser Health, and Patrice Strike from CLBC, and Dr. Amy Hung. And Dr. Amy Hung is a family physician in Burnaby. She went to UBC for medical school, but she also worked took a fellowship in developmental disabilities at Queen's and worked at the Asante Center providing primary care for individuals with IDD. And now she's practicing family medicine in Burnaby. And without further ado, I'll pass it over to Dr. Hung.
Thank you for the introduction. Thank you everybody for attending this talk. So I'll be talking briefly about how to support aging adults with disabilities and when. And if we can get the slide deck going, I will just first start by defining the term disabilities for this talk. I've referred it as a group of intellectual and developmental disabilities, or shorthand is IDD. And this is a constellation of conditions that result in variable limitations, including physical, cognitive, social, or practical skills. We know that in Canada, there's at least 0.5 to 1% of adult Canadians living with IDD. And compared to the general population, our group of individuals with IDD generally have more complex health needs. There's usually a higher degree of medical conditions that we look after. There may be concurrent psychiatric diagnosis, and there are common barriers that we often see, such as some challenges with communication and other socioeconomic factors that we consider, including things like the cost of medications or access to healthcare providers or having inconsistent caregivers. That often adds to the layer of health needs that they need. Overall, they do receive less primary care and secondary preventions compared to the general population. For instance, females with IDD tend to have less Pap tests or mammograms done as part of screening for cervical cancer or breast cancer. And with a combination of these factors, they do experience higher level of morbidity and mortality. With the current health standards and the social supports, they are now living longer than before. For those people with mild IDD, we know that they're living longer ages to age 70s to 80s. For those with moderate or more severe IDD, their lifespan is still shorter compared to the general population into the 50s and 60s. As such, we know that we definitely need to increase awareness and educate ourselves into how to support aging adults. In the next slide, I'm going to talk about what happens with aging. Okay, is this, do we just get more white hair or more wrinkles in our skin? I don't think so. I wish it was as simple as that. It's actually quite a significant transition in everybody's lives. It's a our body has new changes, right? There may be some more pain and aches. There's maybe some slower mobility. We get more tired. There's more sleep disturbance, and we may become more forgetful too, right? It's the period of significant transition, not just in our body, but our mind and in our social environment. But in order to know how to support aging adults, we need to know what we are trying to achieve, right? We need to understand some of the basic concepts of healthy aging. There has been a lot of models that talk about successful aging. One of the more common one, the more popular one, I guess, is one shown here. It talks about, we want to avoid disease and disability, right? We want to stay engaged with life, whether, that's having a meaningful goals in your life that you're trying to achieve, and sustaining a high cognitive and physical function. In our population, there are additional barriers that we see. Okay, so for instance, we do see that we experience frailty earlier compared to the general population, right? For instance, for those with Down syndrome, they may start to experience some cognitive impairment as early as in the 40s or 50s. And in our healthcare here, they're actually not qualified to actually access geriatric care, because to access that care, you need to be 65 years or older. Okay, so that's another layer of burden for them to experience. If we can move on to the next, maybe click on a few because they'll show up. Thank you. The other challenge is there's lack of healthcare records from childhood. For instance, in BC, I've had several older clients who lived in Woodlands before, right? So that's a facility that shut down in the late 1990s. But there has been experience of fires, and some of the health records are lost. So I wouldn't be able to know that maybe they had some radiation for childhood tumors, or perhaps they had some cardiac surgeries when they were a child, right? So these records are lost, and that's going to be harder for us to manage and prevent other secondary conditions from forming. There's often delayed symptom recognition from a combination of barriers in communication or inconsistent caregivers and physicians that often lead to, perhaps they're just attributing those changes in behavior to be a part of their IDD, right? So that's diagnostic overshadowing. So all of these, because some of our persons with IDD may have a harder time to express some of their discomfort, it may lead to a delay in diagnosis or ordering some investigations. There are often comorbid mental health conditions for instance, dementia or depression, anxiety. So that's all of these sort of barriers for them to become as healthy as they can when they get older. So that's the medical side of things. And on the social side, where we want them to be engaged, there may be lack of inclusion activities as they get older, right? Oftentimes, when we help a person with IDD, we may not be thinking about the future financial situation, right? So there's talks about, how do we help them to become more financially prepared, to help them access funds as they age. Accessing things like respite care for aging caregivers, it can be a conundrum, because often when they are in their 40s or their 60s, their caregivers or their parents are often aging as well, right? So how do we provide them with adequate support for both the patient and the caregiver? Do we have enough support at the group homes, or is there a long wait list at some of the long-term care facilities? We also want to focus on giving them some personal control and independence. I think sometimes, I know as physicians, if our time is sort of rushed, some of us may not be looking at the patient directly when we ask questions. And, sometimes we're not letting them express their own thoughts or opinions. So how do we help them support that, right? How do we help give them and empower them with the power to make their own decisions and discuss things like advanced care planning, right? Are there treatments that you wish to have or don't wish to have? Like, what's important in your life, right? Is food a very important factor for you, right? So when we consider things like tube feeds, right? Maybe that's not going to be appropriate, right? So we want to be able to talk about these things early on, so we learn about their values and their goals. And now we talked about all these potential barriers. How can we help? How can we help them achieve successful aging? Okay. So first of all, we need to do the basics, right? We can talk about the importance of healthy lifestyle choices. Just like the general population, the top causes of death in our population is still cardiovascular diseases like heart attacks or stroke or cancer. Okay, so we prevent these things by starting with exercise, right? 30 minutes a day of cardio aerobic exercise, making sure that we're eating healthy, maintaining weight, and that we're doing lots of, if we can, outdoor activities or even just exercises in our home. Okay, so that can be started as early as, in our 20s or 30s. Okay, and as caregivers or primary care providers, we can talk to them about anticipatory guidance about changes associated with aging, so they're not going to be surprised, right? So some of them, we might not know about the symptoms of menopause, right? Around the age of 40s, they may start to wonder, why am I feeling hot all of a sudden? Why am I having more mood swings? So these are things we can talk to them about early on. Okay, why am I having challenges with incontinence, or that I'm having more pain and aches? Caregivers, we can proactively think about what they need, right? Do they need some more visual supports or hearing aids, right, to prevent falls? So these are some of the anticipatory guidances we can talk to them about. Usually age 40 is when I usually start. And we advocate for supports early on. So whether it's access to transportations, to see doctors or make appointments, or to see physio or occupational therapist, access to behavioral interventions, having some counselings, right? If they're experiencing some losses or griefs in their lives, having that set up early on will be helpful. And of course, then access to respite care for caregivers. And then, as mentioned, when I talked about advanced care plan, we need to explore their values and revisit that regularly. So we know that, when it does come to end of life planning as part of all aging process, we would know what's most important to them and that we can respect their values. Okay. And on the last slide, we'll talk about some more additional things that we can do. So rather than the cartoon here, please do not ask celebrities for medical advice, but go see your primary care providers, okay, or someone who you trust. Okay, anybody you trust, you can ask them about how do I get more help. Okay, so if you have primary care providers, you should know that you have to at the very least, do an annual health check with them. Okay, in Canada, the family physicians have a guideline to say that every year we should do a detailed general health check. And that's different from the general population. Okay, we do a head to toe check, making sure that your eyes are doing okay, you have no problem with your hearing, and that how's your sleep, we check in from head to toe. So that we can pick up on things. So we do that, and we do the age-related preventions at the same time, right? So do pap tests, mammograms, stool tests. Another big thing is we'll check your medications, right? To make sure that you're taking the right ones. Are they still necessary? Is it time to stop? Making sure that you're not taking too many over-the-counter medications, right? For those who are at higher risk of dementia, we also suggest things like doing a baseline psychological assessment at age 40, and we need to reassess that every 5 years. So that's for individuals with Down syndrome. For other with certain genetic conditions like Williams syndrome, we do recommend doing a regular hearing and eye assessment at least every 5 years, starting at age 30. Okay, so all these health checks, can be provided by your primary care provider. Like, don't be scared to just go and see them. If you feel like you haven't seen them for a while, just book appointment, say hi, check in, right? For the specialist, usually, you would have follow-up every 3 to 6 months with them. Okay, for any urgent issues, if you can't access a specialist, still try to contact the primary care providers. Okay, so we can help you in the meantime, and we can also help you reach the specialist as well. I know sometimes going to see a doctor's may be scary, okay, or maybe sort of something you're not used to. We do have some tools to help with that too, okay. There are some forms that we're developing so that you can take you can work. It's a form that you can take at home with you, and you can work on it with your care providers out and write out some of your concerns so that when you see your doctors, they can explore that more with you. There are also some videos on the internet that I think care providers can review with our clients before, so that they know what to expect when they go and see a doctors. And I think last thing I will add in terms of how to help is be persistent if there is something that you're concerned about, right? What could be something as small as like a change in behavior, right? Like, why are they moaning more after eating? If there's some questions that you're not understanding, right? Go ask, be persistent. Don't be brushed off. Always arrange follow-ups until all of your concerns are resolved. Okay. So I think that's my bit of the talk, and I'll pass it on.
Great, thank you, Dr. Hung. And just before we move to the next piece, I did want to ask, and you kind of spoke to it at the end there a little bit. But one of the first things you mentioned was, well, there were two pieces. One, there was around the level of complexity, and I think you addressed that, why that level of complexity is greater in this population. But you also said that folks with developmental disabilities aren't accessing primary care as much as the sort of the average population. Why do you think that is?
So I think it's multifactorial. I mean, firstly, there's a shortage right now.
Mhm.
But also, some of them may think that it's part of their diagnosis of IDD, right? So they may attribute it to that's their current function. That's probably why they're developing these uh, conditions, but they think that's normal. It's not something that needs to be checked out by the doctors, right? So they may not bring up to like the walk-in clinics or whatnot.
Okay, yeah, I mean, because kind of what you said at the end is really there's actually a need to be more diligent,
Mhm.
and perhaps have more contact, and yet we're on the other side of that. So hopefully
Right.
people are hearing that message.
Yeah, and the thing is, sometimes we do have inconsistent caregivers, right? And I understand there's a lot of, turnover with the staff. So it's hard for them to know how the patient is at the baseline, right? To recognize, hey, this is different. This needs to be something that needs to be checked out by the doctors. Yeah, so we need to be more, diligent in terms of picking up some of these clues.
Excellent. Thank you. Thank you so much. And just a reminder, if you do have questions for Dr. Hung, you can put them in the chat and we'll make sure we try to get to them in our panel discussion at the end. I'd like to introduce Patrice Strike, who works with CLBC in policy. She's been with CLBC in policy roles for 10 years, but she's currently the provincial lead and subject matter expert on eligibility, which is what she's going to be talking to us about. She provides consultation and training to CLBC staff and to external partners such as psychologists and government agencies. So she is the expert in this one, and I'm going to turn it over to Patrice. Thank you.
Thank you, Jeff. So, hi everyone, and thank you for inviting Community Living BC. I'm going to refer to it as I speak by its acronym, which is CLBC. And I will also be referring to ID as opposed to IDD. I know the language has moved on, but this is currently the language in our legislation and policy, and we just haven't updated it yet. So, today's topics, I know that Michelle Lung previously attended and talked about eligibility, specifically the criteria and the documentation. So I will be reminding you of that, but also talking to you about the challenges and problem solving for aging adults as they apply to CLBC. So to remind you, CLBC supports, we are a Crown corporation, and we support adults age 19 or older. And it's very specific in the laws who we support, and that is adults with developmental disabilities, as they're referred to in the legislation, and that's ID or IDD, or adults who have an autism spectrum disorder or fetal alcohol spectrum disorder and have significant challenges in adaptive functioning, and they have to meet the legislated criteria for CLBC eligibility. So I keep talking about the legislative criteria, and the thing is, the law in BC is very specific about who CLBC serves, and the tools have been defined and the qualifying assessors have been defined. So it's all very specific in the laws that we have to work with at CLBC. Specifically, it's the Community Living Authority Act and Regulation. So there are two possible ways of being eligible for CLBC according to these criteria, and that's through the developmental disability stream, as we call it. And that would be with a diagnosis per the DSM-5, or sometimes it's still the DSM-4, of intellectual disability. And that includes, an assessment of that includes impaired intellectual functioning and impaired adaptive functioning. CLBC has an additional requirement, which is not a DSM-5 requirement, but we are required to determine that age of onset occurred before the age of 18. So if a person is not eligible based on a developmental disability, they may be eligible under our personalized supports initiative. And that would be the case if they have significant limitations in adaptive functioning, which the law actually defines as 3 standard deviations below the mean, and they have a diagnosis of ASD or FASD. So psychologists provide the diagnoses and the testing and the results, and CLBC staff use that information to determine eligibility, and they do so by collecting documentation that confirms that an individual does meet the criteria. And so those assessors, as I say, are registered BC psychologists, or in some cases, it's school psychologists. And the documents are specifically an assessment, that's the report after you were assessed, which says that you meet the diagnostic criteria for intellectual disability cited in the DSM-5. And then we have forms, which you'll see shortly, that they fill out to sign their names to indicate that, yes, they've either assessed someone or assessed someone plus looked at other documentation and confirmed that the person does meet the criteria. So then if a person actually does not meet the developmental disability criteria and they're applying for CLBC, under the PSI stream, then we're asking the assessors to complete a form which confirms that they do not have an intellectual disability, but which confirms that they have the other diagnosis of an FASD or an ASD, and then they also provide the adaptive assessment report, which shows that the person has the significant limitations. That's the 3 standard deviations. Yeah. So these are the forms, and we're expecting for any assessors who may be here that you're filling out these forms. As I said, sometimes an assessor, for example, if you've come from outside the country, may be able to look at forms that you had from outside the country and conclude that, yes, there is information which confirms that you don't have an ID, you do have an ID, or that you have ASD or FASD, or what your adaptive functioning is. So the challenges related to older adults, when people come through the school system, for instance, it's usually their schools, and the school psychologists are able to they know them, and they've been testing them, doing psychoed tests as they go through school. And so it's very easy. They just complete those forms and they make a transition to CLBC. But definitely we recognize that there are cases where people have never been diagnosed before, and maybe they should have, or the people around them are believing that they have an intellectual disability. And so of course we experience more and more, people who, as everyone ages, either their parents are aging or they are, and they're finally coming to CLBC for supports. And the challenges that our staff have with determining eligibility are related to either having enough information or having appropriate information. And so the problems will be with the actual diagnosis or the actual documents. And the staff are required to have sufficient to make an eligibility determination. And specifically, one of the problems is getting confirmation that an individual's cognitive challenges are due to an intellectual disability, because as Dr. Hung mentioned, there are so many other issues that people start to face, as she said, dementia, depression, anxiety, and other things that cause a person to appear to have they are having cognitive struggles. But the question is it an intellectual disability? Because under the law, that is who CLBC services are for. Another specific problem is confirmation of an intellectual disability with onset before age 18. And that's really probably our biggest struggle with people as they age, that as you get farther and farther away from school age, there's less chance that we have any information about your history. And assessors, I have observed, will try very hard to make an educated assumption about that when they feel comfortable doing so. And so sometimes they will actually confirm on one of those forms that onset was before age 18, but we ask them to provide information to indicate on what they are making that educated conclusion. And in all those cases, then we have a secondary review by a consultant to make sure no one's missing anything that maybe should have been considered, And then a third very specific problem, as I said, is the lack of documentation. Sometimes people have nothing at all. And we know that sometimes people just had different lives. They were not in the school system, or they're perhaps refugees from another country, or many reasons that they have no documentation, or they have no collateral information, meaning they have no others who can provide information just orally, people who know them, family members, their parents, support workers, medical professionals, anyone. And a fourth item is that they often lack appropriate assessments if they've come through the mental health facilities, for instance. Often they'll get assessments, but those assessments they're not necessarily conducted for the purposes of CLBC services, so they may lack things like a look at an in-depth look at history, or they may not do an adaptive, or a person may have just another significant, complex health needs, as Dr. Hung said, and so they really need help, and so the other agencies don't really know where to send someone, so they often just try CLBC, and so we get assessments in which the people they don't have what is required under law for our supports. So CLBC staff will really work very hard to find and to support families and support networks to find information to help us determine if a person is eligible for our supports. I'd like to point out, first of all, that CLBC supports are voluntary, and individuals, as an adult, you are not obligated to come to CLBC if you're not interested in our services. You are not obligated to apply to us, and we require the individual's consent unless there is someone else who is legally able to provide that consent for them. But if we don't have the appropriate consent, we won't be looking at any information at all. CLBC our staff will ask for what documents you have. So I suggest that in advance, any pieces of paper you have, report cards, old school medical records, anything at all that might help prove that you meet our requirements, we would be interested in seeing, even if it doesn't look like something that's very significant to you. It might help us. I also suggest, if you feel comfortable, call CLBC, like actually phone your local CLBC office and ask for the eligibility facilitator to learn, to get information, especially about obtaining assessments. I'd suggest that you not go out and get any assessments until you talk to the facilitators before, because they are our best resources on what is available for assessments. And CLBC actually, we refer people for assessments ourselves if we have reason to believe that you're going to be eligible. We don't provide assessments for people who don't want our services. They just want, a diagnosis. We only would consider providing, if funding an assessment, if you're interested in our services and if we think you might meet our criteria. But the eligibility facilitator can help you not do things you don't need to do, and to move your search for information along as quickly as possible. But if you prefer, you just you don't feel you have to call us, you can simply get on our website, and there's plenty of information on there. But also, you can contact us, and it really doesn't matter as long as you can click on the link that says contact us, ask us any questions, and we'll route it internally, and we'll make sure that someone answers you and starts to help you. So we look forward to helping anyone that we can. Thank you.
Thanks, Patrice. That's great. I have a bit, and I think we'll have more questions along these lines. But just before we leave you, I think that one of one of the reasons with this particular Doc Talk came about was we talked about, and I think Dr. Hung mentioned it as well. Sort of aging adults, DD adults. Who may not have realized that they might at a certain point need services, and are realizing it now. And what you described is, to me, what I heard was, the longer you wait, the harder it may be to find to track the proper documentation down. Is that true?
Yes, Jeff, absolutely. I'd say that's the case. And yet we know what happens, and we certainly will work with anyone. But
Of course,
yeah, really, ideally, the sooner that you come to us, the more likely that we can find information.
So then, I mean, if it's families, and
Yeah.
and their families, and that are providing, sort of the supports so that if folks feel like they don't at the moment need those supports, it may be worthwhile to say, is there a point in the future where those supports, what the CLBC offers, would be valuable? And if there is, it might be a good idea to start to move down that road now.
Yeah, I think that's a great idea. And also, I think too that if a person looks at the website, they may realize that there are more supports than they realized, or different kinds than they realized, and broader supports, that maybe they're not even realizing what possibilities there are in terms of supports.
Yeah, it supports for the individuals, and also for their families, I would imagine.
Exactly. Yes.
Yeah. So understanding what's out there at the moment, and also being able to plan for the future.
Well, we do a lot of plannings, definitely. So, I mean, we're always thinking in terms of transitioning planning. But yes, absolutely. If a person thinks someday they may want CLBC supports, I would say that's a good time to start applying.
Yeah, as soon as you have that thought, good
Yeah.
time to make that call. Great.
Yeah.
Thank you. Well, I know we'll have some questions for you as we come to the panel. Now I'd like to introduce Rod McDonald. Rod's a regional manager in Fraser Health. He leads the Health Services for Community Living team, Choices and Support for Independent Living, Nursing Support Services team, and the Child Services Resource team. Rod is a busy guy, so we're glad to have him here. He was also with Fraser Health and acquired brain injury services, and he spent many years in community mental health and substance use as a clinician and team leader. So without further ado, I will turn it over to Rod.
Thanks, Jeff. Thanks everybody for attending today. So I'm going to focus in a little bit more on dementia per se. So health services for community living, really, which is the most appropriate team today, because we're talking about older adults. That's like home health for adults with developmental disabilities. So all the people that we work with have to be eligible for CLBC. So they may not be receiving services from CLBC, but as long as they're eligible, we'll continue to see them. And I realized I didn't put my contact information down on my slide, so I'll probably do that in the chat. If you have any follow-up questions, you can just email or call me directly. Next slide, please. All right, so in Fraser Health, also provincially, there is a big initiative on aging. And there is a provincial dialogue occurring with CLBC, health authorities, the Ministry of Health, contracted providers of CLBC, and we have some family and individual representatives as well. And if you look at this chart, this is from CLBC. You can see that folks are getting older. Well, people are living longer, as Dr. Hung mentioned earlier, because of advances in healthcare and community care. So because of the chromosome, the third chromosome 21, people with Down syndrome, they are at particular risk of Alzheimer's disease, because that's also the chromosome that's implicated in Alzheimer's and accelerated aging. So this is a new demographic trend. And so systems across modern economies around the world are catching up with this new reality, or not so new now, but emerging, still emerging. So other people with other forms of developmental disability are at the same risk for dementia as the general population. So we want to be concerned about everybody, but people with Down syndrome in particular are at high risk. So next slide, please. Yeah, so I've gleaned this information from some research I was able to do. So by age 40, we should set out a baseline for screening for dementia, and there is a tool that's out there by the National Task Group on Developmental Disability and Dementia that is widely known with CLBC and their contracted providers. You can see that the rates of Alzheimer's disease are quite high compared to the general population. And the mean age of onset the average age of onset is 53, which is quite a bit younger than the general population. And then the progression is also rather fast. So not only do people get features of Alzheimer's disease younger, the disease progress is faster than it is for the general population. So there's a couple of different studies that are included in this page here. So you'll see there's some differences, mean age of onset 53, 54. That's probably as confident a number as there is in the literature right now. There's probably a lack of research in this area, but the research too is an emerging trend. So in the past, parents would typically outlive their child if the child had Down syndrome. Now that's not the case. So we do have situations of what we call compound caregiving, where both parents and the child require home support, personal care, that sort of thing. Next slide. Okay, well, we've already talked about Community Living BC, so thank you, Patrice, for that. I do want to bring you to your attention the Aware Share Care webpage. That is CLBC's designated online resource for aging. And I know that it's going through a major review right now due to the provincial review on aging. So CLBC is doing a lot of work on that. And I think that will be an excellent resource for all facets of aging, where to get services, what issues to expect, what issues to think about. So that, just keep that link on your radar. And then I noticed in the questions that were forwarded to us in advance of this presentation, people asked about advocates for whatnot. So keep also to the CLBC advocate for service quality. Keep that in your mind, because they report directly to the Minister of Social Development about, and they address quality of care questions from the community about all services related to CLBC. CLBC is, they're an equal partner at the table with HSCL in our region. We have a very close relationship with them. So, I have some involvement with the advocate for service quality too, because sometimes questions come in about health services for community living. Next slide. All right, so keep this slide. I did put in my contact information. Jeff, can I just ask, is the slide presentation going to be available to the audience?
Yes.
Perfect. Okay, so keep my name and number, and feel free to call me if you have any follow-up questions. All services that are related to home health in Fraser region, like also long-term care, home support, assisted living, all that has to go through this home health service line. It's like a one-stop shopping referral system, and then they connect with us. So that's how you can get connected to us. And if you have just questions about what's available in the region, you can go to CLBC. They have a web page, or you can contact me and I'll help guide you in the right direction, or put you in touch with my staff. So we do have nurses, occupational therapists, physical therapy, dental hygiene, dietitians. So these are folks that go out and see people one-to-one in their homes. And we're busy doing that all day across the region. That's Burnaby to Boston Bar. And we also have some nurse case managers that help assess for what's called added care funding, which is funding for personal care issues. And if someone needs or wants a referral to long-term care facility or assisted living. I'll just go to the next slide and I'll give you a general update. So advanced care planning, you heard someone mention that before. I recommend that you keep that. And then developmental disabilities, mental health service, that's all available. The Family Support Institute, they are support to family members. So they're good to help family members get their needs met and to meet with other family members. Same with Inclusion BC. Now, developmental disabilities, mental health service, that is a service, but it's kind of a special service for assessments for people with really complex challenges. Other mental health centers, the generic mental health centers, they will see adults with developmental disability if they've got a mental health problem all along. And I know that because I worked with those folks when I was in mental health, not about a decade ago. And when we're talking about dementia, I just want you to be aware of the National Task Group on Intellectual Disabilities and Dementia Practices, the Canadian Consortium. We have a strong relationship with that group now. And then there's also the Specialized Seniors Clinic in Fraser Health. There's an office out of New West, but it serves Burnaby, Tri-Cities and New West, all those areas. So they do see folks with developmental disabilities and dementia. And then the Burnaby Division of Family Practice is, we've built, I think, a very strong link to the Burnaby Division, and I'm very grateful for that because we've got Burnaby Division in our list of stakeholders, external stakeholders. Through successful advocacy, developmental disability and dementia is now a part of the Fraser Health Regional Dementia Planning. We're building community care pathways. So where does someone go to get assessed for dementia if they have DD, and how do they get access to specialists, et cetera. We just had a big meeting yesterday, actually, with our internal stakeholders within Fraser Health, and we've got physician representation there. And, a big part of that work is going to be how do we support family doctors, because that's going to be, family doctors and services like the division are going to be absolutely critical partners in this planning process. So that's an ongoing planning, and we've got Inclusion BC, Family Support Institute, Mental Health and Substance Use. We've got all sorts of the Alzheimer's Society. We've got a whole list of players, and I've got big ambitions for this work, and it's coming along nicely. We've got a family representative. We're looking for other representatives too, to help make sure that the voices of people with dementia and DD are heard, and that's a critical theme. Hold the person's story. So, for example, when someone with dementia lands in an emergency department, one of the questions that families are asked over and over again is, were they always like this? So we need to know how the dementia is impacting them versus their DD. And like, I think it was Patrice who maybe mentioned this, or Dr. Hung, is that sometimes in busy acute care sites, for example, it's very easy for people just to sum everything up as a result of the developmental disability, and people can get undertreated. So that's just something I think Jeff was right, that we do need to be somewhat vigilant about making sure that issues are addressed appropriately. With the National Task Group on Intellectual Disabilities and Dementia Practices, if you go onto their webpage, you'll see that they have an early detection screening tool, which is meant to be used by families, group homes, it's not a professionally designated tool, but it does give a bit of a screen, and a baseline at age 40 is what's recommended for Down syndrome and dementia. So basically, we're pulling all this together, and we've advocated that DD and dementia be a part of the provincial dementia strategy, and I'm lucky to have had a chat with the new executive director for that portfolio, and she's actually very knowledgeable about this need, and so I have high hopes that we'll be on the radar for the Ministry of Health, which is great. And I know that our group of folks is also noted on the Canadian federal dementia strategy as a high-risk population. So I'm feeling like it's all coming together, but it's going to be more work, and it requires teamwork. It requires all of us working together to make sure we sort out who does what and how to be accessible to the general public. So if you have any questions about dementia and developmental disability, I welcome you to email me about it. And I'm trying to create visibility on this theme. And I want to put out a special thanks to the Burnaby Division of Family Practice, because you folks have been such powerful advocates and strong allies in this process. It just makes all the difference. So next slide. Oh, those are just my references. So I suggest you take a look at those. There's some actually quite good resources on YouTube. That's kind of where I went, because there is a lack of good solo literature out there, but we're working on it. In particular, I recommend the bottom two, UCI Mind. That's a YouTube channel. They have really strong YouTube videos that involve experts in San Diego. And I found them particularly helpful. So I think that's it. Is there another slide? Okay, that's me. Thanks, folks.
That's great. Thanks, Rod. And before we move along, I have a couple of. I know that you spoke about the challenges for physicians and for families. I'm just curious. I mean, we've heard a little bit of lived experience where families may find it. They may have some level of fear or confirmation bias around. Is this a change? Really detecting change and understanding the shift to dementia in adults with developmental disabilities. Do you find that that's something that families who are supporting sometimes have a challenge around?
I would say absolutely yes, because I think it's something that is really coming onto everyone's radars as professionals. So I can only imagine that for family members, they may or may not be aware of this issue, and they may just think there's something else going on. Now, of course, as Dr. Hung mentioned, we have to rule out other medical challenges, but aging happens to us all, and some of the things that happen with aging, with dementia, it can be subtle changes at the beginning. So, for example, often there are personality changes and also mobility changes, but it's not cut and dry, so one could easily think, oh, there's something else going on and not go to dementia. So it's important to hold dementia in one's mind as a potential problem, but also the sooner we start to screen and baseline, like at age 40, like someone can dress themselves, feed themselves, get around, transfer, find directions in the community, then all of a sudden they have no interest in doing anything. Was that depression or is it dementia, that sort of thing? So I would absolutely have to assume that families are tremendously challenged by this area and need more information.
And I guess it's that same thing. There's fear of the diagnosis. I mean, and I think
yes,
in the population as a whole, we have fear of that diagnosis. But it's the caution is the sooner that diagnosis comes in, the more likely you are to get great supports for it.
Yes, I mean, it does take time. We all know it takes time to get to a specialist, and we have fantastic geriatricians and geriatric psychiatrists, knowledgeable physicians and clinicians, but workload is always a challenge, and we want to get this sort of identified as soon as we can. So the early detection screening tool from the National Task Group, I highly recommend families can just start using that themselves. And just again, holding the person's story. I think this is familiar to many. And so when you go into the hospital, if you do, and the physician or the nurse is saying, have they always been unable to speak? Have they always been unable to feed themselves? You'll be able to say, no, this is new.
Yeah. I mean, and you also speak about family doctors, and I know
absolutely.
We've talked in the past about family doctors who, sometimes it can be hard to attach patients because they may not have the experience or the time. They're getting more time now, but I would imagine that this kind of diagnosis is maybe new for many family doctors as well.
Well, my belief is that it must be. And a big emphasis that I have is how do we do community continuing medical education for this area? How do we organize that as a region in Fraser Health? And how do we link into things like the National Task Group? And I'd like to see an annual conference, but these are my big ambitions. A provincial conference on DD and dementia would be excellent, and we would have physician, that would be open to everybody, but we would make sure that GPs have their needs met in forums like that. So there's a lot of groundswell that needs to occur, and I think if I encourage physicians to work through Jeff and Hui and Azra and to bring your voices to the table. The more physicians that do that, the better it is, and the greater the case. It lets me make a case within Fraser Health that we got physicians in our region that are calling out for assistance, and what are we going to do to support them, et cetera, et cetera. So the more we raise awareness, the better.
Great, absolutely. Thank you. That's great. And I know there'll be some questions for you. Pam Balag is with Possibilities. She's an assistant program director, and she has over 30 years of experience working supporting individuals as they age. She has some success stories to share and some tools that I think will be really valuable. Pam.
Hi. Thank you. So the first one is slide that we have here is anticipating additional supports as we age. So one of the things here at Possibilities that we do is make sure that we do individualized care plans. Next slide. So part of that is looking at a person's current living condition. So we do support individuals referred to by Community Living BC. And we offer a full range of supports, including purpose-built homes that with BC Housing. And these homes are particularly helpful for those people who have dementia or who have other mobility issues. So the homes themselves might have things like ceiling lifts, they might have accessible washrooms, and they may have large areas to accommodate a few people who may be using wheelchairs. And in those homes, we have a staff team and that are trained to support people who have Alzheimer's or other mobility issues. The next slide. We also support people in outreach, so they might be living in their own home, And that would be helping them get to medical appointments. And even if they're wanting a staff person could attend the medical appointment to make sure that they're understanding what's being said to them. They might take notes, maybe take them shopping to make sure that they're getting their proper food, helping them with any housekeeping type of things. So if they're not able to cook that well, they might help them with teaching cooking skills and of course socialization. Shared living is one of our supports where the person receiving care is living with someone in community. So it might be in a person own home, or the individual receiving supports may have their home where they share the living space. And another one, of course, as I just mentioned just a little earlier, was in the supported living licensed homes. So again, these homes are regulated through community care facility licensing. In those homes, we really do rely on the services of HSCL. And when we have a person living there, they'll help us do a care plan, which includes a health care plan. And that includes using the occupational therapist to help us set up a plan to how do we safely transfer this person from their bed to their wheelchair? How do we make sure that they're receiving a proper diet? So many of these individuals may require a specialized diet that includes textures to their diet. So maybe they're not able to swallow properly. So they might need pureed food. So the nutritionist would help us with making sure that we know how to puree food properly, so there's no, lumps that could cause choking hazards. So HSCL has been invaluable for us as a resource. We also making sure that we utilize the other supports that are available, such as the Alzheimer's Society. The National Task Force has come in and helped us train our staff to then go into our homes to train the staff in those homes to be able to provide dementia care. Next slide. So in our homes, we make sure that we have lots of stimulation and interaction and that we're engaging so that we can meet our vision, which is good full lives for everyone. So part of our care plan includes social interactions, making sure people have a full range of goals that includes getting out into community, making friends, having new experiences, and maybe trying things where it's something new for them so that they're being engaged. And then here we have pictures of persons in their own home, and they're looking like they're doing crafts, and then of course celebrating what they've just made. Next slide. So part of the importance of having relationships, as Rod spoke to earlier, is when you have a stable staff team, you're able to get to really know the person. And what our staff team is looking for are changes. So as we get to really know somebody, we know when there's something maybe off, and it's catching things really early. So it might be something very subtle that now, person's not giving eye contact, or the person's not talking as much as they usually do. They're very subtle things, and being able to recognize that really does mean that we have to be able to have a stable staff team. And sometimes that's not really possible. So that's when we go to our documentation and making sure that we're documenting things so that we can see when there's changes. We do an assessment at the age of 40, and then we go back to that to see if there's changes. Now, for some individuals, we also will videotape them doing specific tasks. So it might be, doing up buttons. Are they verbal? We'll have a little discussion that we'll record. And then look at that 10 years later. Are we seeing changes? And that way we can plan for people. And if we're seeing some changes, we're making sure that we are going to getting the medical assessments done right away so that we're not working in a crisis. Some of this might be getting family involved and asking them what they see, what's the history, and having really good, full information so that we can be proactive. Next slide. And this is where I just talked about videotaping and making sure that we are getting information as quickly as we can. And again, this picture here that we have, it was a celebration at one of the homes. So we do lots of celebration and making sure that people are emotionally engaged and have fun in their life. And then the next slide. And these are some of the resources that we use, along with, as I said earlier, HSCL has been invaluable. CLBC, and there's just a whole host of supports out there available. We just really do depend on them to keep us making sure that we're giving the most excellent care that we can. Well, thank you very much.
Thank you, Pam. And I have a couple of, as I'm listening to you, and I'm actually going back and thinking about Rod and, the lived stories, and particularly, you keep your finger on changes, and part of your role must be to support families through and caregivers through those changes, because sometimes those changes, I would imagine, can be dramatic. Sometimes you can support people as they change, but sometimes it may mean a change in living circumstances. It may mean bigger shifts. Is that something that you also do, is really support the families in those relationships?
Oh, absolutely. And our families are, fundamental in helping us make decisions. They're part of the process of making decisions. And one of the things that, we have to recognize is that things can change rapidly too. So being able to get family on board early on in the process and having that relationship it helps us when we have to have those tough conversations to be able to say, maybe your son or daughter, we're going to have to look at maybe a different living arrangement for them because they're not going to be able to do the stairs where they live. Or, they're not going to be able to live independently based on the diagnosis. So relationships are so very valuable, making sure that we build those and build that trusting two-way conversations.
Mm-hmm. Yeah, and for families to feel supported in that change must be incredibly valuable.
Well, I think they appreciate that, and we certainly do. We appreciate their input because they have a lot of history. Family history is important too, oftentimes making a diagnosis.
Yeah, and I mean, I think that, if I can really reflect through COVID as we talked with folks in this just kind of in this group, that, often families felt alone. And I think what we've heard all the way through all of the presentations today is, it can be isolating, and there is an awful lot of support out there. There's an awful lot of help out there. And hopefully, if you didn't know where to get it before, this will be helpful to you. Each of the presentations has some really great links and connections to it, including some of the folks on this call who have said, call me, which is pretty great unto itself. So thank you. Thanks, Pam. And now, just as our last speaker, we've got Heather Johnson from BACHI. And Heather's been with BACHI for 8 years. She focuses on development, implementation, and delivery of strategic initiatives that align with BACHI's mission of creating a society that includes all people. So, Heather.
Hello. I'm bucking the trend by being the only presenter here without a slide deck, and I'm realizing that I'm slightly regretting it because now you just get to look at my face, which I should have thought of that before. Just wanting to quickly, before I jump into what I want to talk about, just wanting to acknowledge that today I'm calling in from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And I know for me, we're approaching the National Day of Truth and Reconciliation tomorrow. So reflecting on and sort of recommitting to the calls to action from the Truth and Reconciliation Commission report, and would encourage all of you to do the same. Take a look and think about those things. And now back to talking about aging. So the Burnaby Association for Community Inclusion is another large service provider. Pam's done a great job of giving an overview of the types of services that agencies like Possibilities and Bachi can provide. And so I won't go into detail about the types of supports and services that we can provide, but I wanted to bring a little bit of perspective and to sort of hopefully get people thinking about some of the things that we encounter as we support folks who are aging, and some of the pieces that can make that process a lot easier. I'm not going to focus so much on the medical side of things. You've heard a lot of that today from people far more qualified than I, who am not a physician today. So just wanting to give a little bit of context about what we're seeing and some of the things that can be really helpful. And hopefully I'll point to some resources that might be of use. One of the things that I always want to encourage people to do is think about aging, not just for the person, but for networks and family members, caregivers as well. We regularly see those moments of crisis emerge when suddenly a parent or caregiver is hospitalized, and putting that planning into those moments in advance of a crisis moment can be critically important. And part of that is really bringing in that broad network, engaging not just, we always love to see when there's more than a single person who's supporting someone. So a parent, yes, absolutely vital, but bringing in neighbors, family, siblings, other people who can also step in those moments that we can't always anticipate. So that strategy of having a broad network, sharing information, making sure that other people know, where the information might be that someone might need. So if they have specialists or physicians, or when their appointments are, who the contact information is. So just really making that information accessible. We've heard a lot about advanced care planning, and those can be really tough conversations to have. It's hard to think about. It can be scary to talk about. Always wanting to encourage people to have those conversations early, have them often. People can change their minds about what they want over time. And so sort of modeling that and sharing, if you're a caregiver or a parent, sharing what your wishes might be, supporting that conversation to happen and to evolve over time can be really helpful, because it can be really hard in a crisis moment to really get the information that you need. So doing that, sort of normalizing those conversations, and as with all tough conversations, it gets easier with practice. So just really wanting to dive into those when you can. Some of the pieces that are really important that, common kind of things that come up. One is around decision-making. And so understanding that there is a pretty well-established legal framework around decision-making. And planning in advance can be really helpful. So if someone doesn't have a representation agreement in place, for example, going through that process, making sure that there is a representation agreement and that can talk about not just health decisions and advanced care planning, but also other aspects of a person's life, things like the financial side of things, other decisions that are also really important. We heard Dr. Hung talking earlier about people not being able to afford medication, for example. So those financial pieces can have a significant impact on aging. If you are wanting to make a representation agreement, the NIDUS Resource Center, spelled NIDUS, is an excellent resource. They have all of the forms, there's information, there's a registry where you can make sure that is accessible. because having a representation agreement is critically important, and knowing where to find it and what it says is also critically important, or being able to find and access that information. So again, making sure that it is accessible and that people know what's in it and that it's kept up to date. There's nothing worse than going into a representation agreement and, you know, trying to pull information about who can support decision making with a person, and that person is no longer in their life, or, you know, isn't around or accessible. So just keeping it up to date. A couple of things to think about. Jeff, you were sort of mentioning housing and changes around housing, and that can be absolutely critical. I think also recognizing, you know, CLBC is not a housing provider per se. If there is a crisis in the home, there is no emergency housing available. So CLBC doesn't have open beds or funded spaces typically where people can go on an emergency basis. And we see this coming up all the time. You know, someone living with a caregiver or parent, that caregiver or parent goes into hospital or something happens, and suddenly it's a real scramble to try and figure out an effective way to support that person. So really thinking about, is there a plan in that kind of worst case scenario? Is there somewhere that the person can go and be safe and supported, and that they can choose? So you know, don't expect that there's just beds available at a moment's notice, and really planning for that. And again, I think this is the theme of sort of what I want to talk about today, is like talking about it early and often, talking about those housing options, exploring what the person wants, exploring what might happen as those support needs change, but also recognizing that it can take time. It can take a long time to find you know, a home share situation. It can take a lot of time to get into any sort of group-based more supportive housing options. So just really being mindful when you're navigating that it takes time, and planning for it in advance, and thinking about it and talking about it and talking to CLBC about it is going to make it a lot easier to happen when that does need to happen. Recognizing and understanding that there are some financial and benefits changes that happen at age 65. So there's a shift from, you know, provincial benefits and PWD into federal benefits. And so understanding what changes, what you're eligible for. Disability Alliance of BC is a great resource, and they have really helpful info sheets that can provide lots of information about all of the different benefits and changes that happen at 65. Again, plan early. This is like the cheerleading moment of get an RDSP. The Plan Institute is an amazing organization that has Access RDSP program. If you don't know what the RDSP is, it's the Registered Disability Savings Plan. And it is, there's a kind of complicated process to open an RDSP, but there's matching money. So you can, you know, when we're talking about financial security as someone ages, it's critically important. Plan Institute has a phone number that you can call. There's people that will help to navigate that. So really just understanding, you know, what some of those financial resources are that are available. I'll stop there so we can get into panel discussion, because I think there's going to be lots of interesting things to talk about, but thank you.
That's great, Heather. Thank you. And but just before we go to the panel, I mean, and I think you've underlined what we've heard already, and pointed to some new areas where it's like, do this sooner than later. Think about the outcome, and I think that's good advice for everybody in the world. But there's a greater focus on this population. How the pitfalls are deeper. But I'm curious, because as I hear of all these resources, and they're great resources, if I were a family and I were in that place, my head would be spinning a little bit.
Absolutely.
Is there a navigator that folks can access, or is it always up to the families to kind of work it out themselves?
Well, I think there are absolutely, I think this is one of the challenges, is that there are so many resources to support that it can be difficult to navigate. But I think knowing that there are some really great resources that can help with that navigation. So I know a couple of people have already recommended FSI, or Family Support Institute, and they can connect families with peers. You can, they have a matching program where you can have a peer that can support you to identify some of those pieces and move through. They can support around medical appointments, that kind of, all, you know, it's a fabulous resource. Disability Alliance BC has great resources as well, just in terms of really clear info sheets. And then I always like when there's, you know, when you're able to just call someone and ask your questions and they can help point you in the right direction. So it is, there is so much complexity. There is so many resources. It can be incredibly confusing. And, you know, if you can work through those one at a time, over time, you're going to get everything lined up. It is difficult to do everything all at once, but
probably,
you know,
it's probably not a good idea to do everything all at once.
No, but the sooner you can, the sooner you, and I think for me, it's like, there is so many things to consider, and doing it in a crisis moment is impossible. And so if, as much as you can do in advance of those moments where a health crisis occurs, or, you know, people are experiencing the impacts of aging, or lives are changing, that sort of thing, doing it in advance, you know, getting a representation agreement in place as someone turns 19 and is entering adult services. Same with RDSP. Like, a lot of that stuff can happen really early. Yep. And so lining those pieces up is early, but it's, you know, it's never too late.
Never too late, or never too early.
Yeah.
Maybe I'll invite the rest of the panel back, and there's something you touched on. I'd like to hear other folks what they might think about it as well. One of the things that we haven't talked about is peer support, and I think you kind of pointed to it. This could be a critical tool for folks if they have peers with lived experience who they can share. Can anybody speak to that? And Heather, you're welcome to, or others. That would be great. Peer support networks, or no? No. I know that there was a question of it out there. BC People First. Is anybody aware of BC People First? Yeah. And that's a peer support network that folks could access.
Well, I can't remember offhand, Jeff, but I think it has a self-help component. I'm sorry.
Okay, no, that's fair. That's fair. I do know that, what we know is, a number of folks have mentioned the concept around lived experience, and being able to speak to someone who has been there or is there is always a value. So and we'll dig into that a little bit more around BC People First, and see if we can't make that there's a little more information available to that. There were a couple of questions in the in the chat that I'll bring forward. One was actually to Patrice, and it was, we've mentioned HSCL quite a bit today, but there was a question around which, Patrice, if you have this answer, which healthcare services are available from HSCL, and how can they be accessed? Do you have that information?
And I was thinking Rod was actually a person to answer that.
Yeah, okay. And that's,
yeah, it was in my slide presentation, how to make a referral to the home health service line. Yeah, anyone can make a referral.
Yeah,
and so we have nursing, occupational therapy, physical therapy, all that stuff.
Right, great. Yeah, the other one that comes up, and this may be a divisional piece, but actually, Dr. Hung, you may be able to answer it as well, is around the issue that we always have. We've been telling people, get to, particularly around medical, get there early, but what if you don't have a family doctor, and how should folks address that?
Yeah, well, I mean, that is a really big issue right now. I would say if you can't find a walk-in clinic, we have lots of urgent care centers now. And I think that's a good place to start if you have any, medical issues that's not being addressed. Nowadays, if there's sort of smaller, minor ailments, then a pharmacist can also help with prescribing some of the medications and treatments as well.
There is a registry, and I don't know, Huey, if you want to speak to the registry, that would probably be good. Or not? Huey there? Oh, there you are. Yeah.
Hi, folks. So for the attachment registry, we are now defaulting to the provincial version, which is through Health Connect. So for some folks who are familiar with, we previously, through the Division of Family Practice, was maintaining our own wait list, but part of the province's mandate was to move towards using Health Connect. And I will send that with all the other resources in this call later on, the link to Health Connect to sign up for a family doctor. The current wait list for Burnaby is approximately 1 year, but I think what you can also do with folks with complex care needs is we are able to take partner referrals from our partners such as Pamela from Possibility, as well as Heather from Bocce. So they can do a partner referral and we can triage and then put forward the more complex patients to make sure that you have timely care.
Thank you. Yeah, I think that's, it's always a challenge. I will say that, just as an anecdote to this, we're working toward developing a new clinic in Burnaby in the Edmonds area. And that clinic will have a focus on vulnerable populations. And one of the vulnerable populations that we'll focus on will actually be the aging population, and this will fit into that. So I think there's an opportunity there, and we'll certainly keep you up to date on that. There's a question here that's a really great question that we didn't talk about it at all, and I'd be interested to hear how the agencies and also the health authority would consider it, which is around seniors with language barriers and folks with developmental disabilities with language barriers. Are there services that you can access? Is this a challenge, and how do you overcome that? Even from a CLBC point of view, what can you do to support families and individuals with language barriers? Rod, I think you've got your hand up. We can start there.
It's always a bit of a challenge, but we do in the health authority have access to interpreters, and it also becomes very important to have working relationship with family members, other care providers, that sort of thing. So yes, and it is recognized that we need to be fluent in multiple languages as we continue to deliver services, including on dementia. It's an ongoing challenge. I won't say that it's always easy, but it is certainly something that we're aware of.
It seems like it's this double isolation piece, for families. So it's, yeah, and I know in Burnaby it's always a challenge with 60 languages spoken. Patrice, go ahead.
So on our website, we do have information sheets available in a number of languages. And if a language is not there, we would take it upon ourselves to go out and find, a translation. And also government has its own preferred vendors. So we actively, that we have access to. So we do have access to translators and interpreters when we need them. Generally, if it's for an assessment, when we're contracting with a psychologist, that includes, if needed, the funding to get an interpreter.
And I wonder, do you, and maybe this is a question for Heather or Pam, do you ever link with some of the settlement agencies in the community, or is that something that you've had an opportunity to do?
Yeah.
I can start with answering that one. We do work with Mosaic. We also, our behavior consultants, they have an online app that they can connect with that, well, we do have to pay for the service, but they can, they have hundreds of different languages, so that if they're meeting with a family within the province that speaks a different language, they can call up and connect with an interpreter and who can interpret for the family. I can't off the top of my head recall what the service is. There's a few out there, and of course they all come with a fee. Some of them come with maybe 4 or 5 language choices, but this one that we just newly discovered has hundreds of different languages, and we've used it, I think, half a dozen times so far, and it's worked really good when our consultants are meeting with a family and they're not able to speak that language. it was a huge barrier before because the consultant may only have one language or two languages, and we're supporting like 600 individuals. So the chances of them speaking a language that our consultant, it's very high. That, so that, of course, that's been a huge benefit, and we'll continue to explore different options.
Great, thank you. And I would imagine go ahead, Heather. There's also culture as well as language.
Yeah, I was just gonna say, yes, we're using whatever we can, and the fee can be a barrier sometimes, and we probably would benefit from interpretation far more often than we're able to actually have it in place. Yeah. We definitely appreciate when there's medical interpretation available for medical appointments specifically, because in those, we're in support settings in community, we're relying on things like Google Translate and those, the really widely available kind of tools. But in a medical setting where that accuracy is really critical, we don't want to be relying on those kind of tools.
That's great. And I'll finish with Dr. Hung. Go ahead.
For those with really advanced dementia, sometimes expressing the language is going to be difficult too. So in those cases, we would involve speech language pathologists, SLPs. They can come up with some communicative devices to help, or communication boards to help them express their thoughts.
Excellent. Well, thank you. What a great presentation. We've unfortunately run out of time, but there are some questions that we'll be able to answer when we distribute the information around this. All participants will get a link, and so I think some folks have asked that. I just really want to thank the panelists today. It was a wonderful presentation. It was it was varied. It was really interesting, and for me it was really valuable. So I can only imagine that the folks who've joined would feel the same way. Again, BurnabyPCN.ca is where you'll be able to find this. I think that you might get a slide on some language some translation services at the end here. And also, before we go, we hope that you'll take just a couple minutes to fill out a little bit of a question and answer, just an assessment of how you found this session. And with that, I will turn it back over to Huey. And again, thank you everybody for who's participated, and everyone, and the panelists especially. Really well done. Really appreciate it.
Thank you so much, panelists. So you're welcome to leave the call. Thank you so much again. For those who are on this call, if you can take a moment to give us your feedback via the poll, that would be very useful and helpful for us to plan these talks in the future. That last slide there just has some information on language specific supports as well. So in addition to the slides, we will be compiling a lot of these resources into a one-page format for ease of use and share it outwards to everyone that's been registered to this call. So we have your emails we will share out. Prior to the panel discussion in Dr. Hung's presentation, she also mentioned a communication tool, which is the forms that we have developed specifically for Burnaby. We will also be sharing that out once it's ready. Thank you so much for being on this call and taking a moment to do our poll.